And then Victoria, on your end, with me having kind of zoom up on my screen, are you able to see that with my screen sharing?
Yes.
Okay, so I'll have to minimize that. Just wanted to check. Are you seeing that now on your end?
All I see is your presentation, your
Okay.
PowerPoint, so you're golden.
It's got like a tiny little screen hiding up in the corner, which is nice to have.
You can let me know when you're ready to go. I don't know how long you want to give it.
Yeah, I'm ready to get things started. People can kind of trickle in as they're able.
All right. So good morning, everyone, and thanks for joining us today. I'm Dr. Vicki DeVoe. I'm a licensed clinical social worker. I'm one of the part-time instructors here at University of Kentucky and also a graduate of this program. Before we get started, a few housekeeping items. If you've not already done so, please be sure to mute yourself so that we minimize background noise during the presentation. And for attendees who would like CE credit for this presentation, you must have registered via the Training Institute. You'll receive a follow-up email after the session that gives you directions on retrieving CEs. The presentation will last approximately 60 minutes, followed by 10 to 15 minutes of question and answer. So I would like to take a moment to introduce Sarah Whybark. Sarah is a dedicated mental health professional committed to advancing access to innovative care in behavioral health. She holds a bachelor's of social work degree from Concordia University, Portland, and a master of social work from Barry University. Currently, Ms. Whybark is a doctoral candidate pursuing a doctorate in social work at University of Kentucky. Her research focuses on expanding access to coordinated specialty care programs for individuals experiencing first episode psychosis. Ms. Whybark serves as a psychotherapist at Providence Behavioral Mental Health Urgent Care, where she addresses acute mental health needs. Her work emphasizes compassionate care and evidence-based practices, reflecting her belief in timely, tailored interventions. Driven by her research, Ms. Whybark explores ways to bridge gaps in access to care for those facing first episode psychosis through innovative program development and advocacy. She's committed to reducing barriers and improving long-term recovery for individuals and families navigating complex mental health challenges. With her combined academic expertise, clinical experience, and forward-thinking research, Ms. Whybark strives to make a meaningful impact on the lives of her clients and the broader mental health field. Please go ahead and take it away.
Thank you so much for that lovely introduction. So welcome everyone. Thank you for joining. My name is Sarah. I am going to be spending this next hour really diving deep into first episode psychosis and coordinated specialty care programs. As Dr. DeVoe mentioned, here's a little bit about me and my experience. I have 9 years of experience serving adults with acute mental health needs, both through inpatient and outpatient settings. I previously lived in the state of Florida, where I worked inpatient psych for 6 years. It's a really great experience that gave me a lot of exposure to folks experiencing first episode psychosis, and I'd really say that's what fueled my passion for this topic. I have since relocated back to my home state of Washington, where I work in the Providence Behavioral Health Urgent Care. It's a very unique clinical space where we are a walk-in mental health clinic. So we don't take any appointments. Folks are able to walk in same day and receive access to care. I am a psychotherapist in the clinic, and I work with a collaborative team of psychiatric nurse practitioners, medical assistants, peer counselors, substance use professionals, and psychotherapists. Moving along to our agenda for today's presentation, I'm going to start by highlighting the learning objectives. There's a few things that I hope everyone is able to take away from this presentation. With this topic being such a niche topic, there are a lot of key terms that I'm going to start with identifying just to make sure everyone has a good understanding of what psychosis is, what is first episode psychosis, and what are these coordinated specialty care programs I'm going to be talking about today. I'm going to be giving an overview of my capstone project. The capstone project for this program consisted of 3 products, which we'll go through here, starting with a systematic literature review, a conceptual framework, which really looked at how do we tie this back into established theories, and then a practice application, which is really going to take a look at my suggestions for really targeting expanding access to these coordinated specialty care programs. Moving towards the end of the presentation here, I'm going to be going through my key findings and implications for the field of social work based off what I found throughout my research. I'll be sharing a conclusion, which really gives a call to action for how we can focus on expanding access. And at the end, I will be facilitating a question and answer period lasting about 10 to 15 minutes. And I have included my references at the end of the presentation for anyone who's interested in taking a look at those. So you're probably asking yourself, why this topic? Why first episode psychosis? As I mentioned, my time working inpatient really fueled my passion for this topic. I saw firsthand clients experiencing first episode psychosis and the impact that has on not only the client themselves, but their families, their support systems, the people who care about them. I've shared a quote here from Lauren Kennedy West. She's a very big influencer on YouTube who shares her journey living with schizophrenia. There was still a grieving period when I first received the diagnosis, because there really are not a lot of success stories in broad circulation about people living with schizoaffective disorder or schizophrenia. Most of what we hear in the news or media are the negative stories about people living with schizophrenia or negative depictions about mental illness in general. So I no longer was sure where I was going to end up, and that added an additional element of fear. I feel this quote really hits home to the experience that I saw clients and their families going through when I worked inpatient and had this exposure. Your general population, their knowledge is what they've seen in the media, and it never paints a pretty picture, really focusing on the negative sides of chronic mental illness. I also saw firsthand clients who really fell through the cracks in the mental health care system, folks who had barriers with insurance, getting access to the services that they needed. Seeing firsthand the benefit of these early interventions for first episode psychosis was a big part of my growth as a clinician and really fueled my passion for this project. Moving along to our learning objectives for today, I hope everyone who's attending today is able to leave this presentation with a thorough understanding of first episode psychosis. What is first episode psychosis? What are the symptoms? What are the age of onset? And what do the treatment options look like? I'm going to be sharing the services that are offered in coordinated specialty care programs for first episode psychosis. I'm going to be sharing today a broad overview of what these programs are, how they came to be, and the positive impacts they can have on the lives of individuals experiencing FEP. A large part of my research also focused on what are the existing barriers to accessing coordinated specialty care programs? Why are there not enough of these programs? And how can we focus on expanding access to these programs? Just to have a check-in with my audience, what is our baseline understanding of first episode psychosis and coordinated specialty care programs? If this is something anyone has heard of before or has experienced either in their personal or professional lives, Would anyone mind just raising that little hand icon there to show me that this is a topic that you have had some exposure to? Yeah, I see a hand up there from Sarah. Yeah, I know when we take a look at this topic, not a lot of clinicians have this exposure or this experience. Often by the time someone is experiencing first episode psychosis, they're requiring a higher level of care, typically an inpatient admission. And so folks who haven't had that exposure clinically may not know. But this is a very prevalent chronic mental health condition that impacts thousands of Americans. And I think most people either know personally or through someone else who's been impacted by first episode psychosis. To set some framework for first episode psychosis, I wanted to share some key terms that I think set a baseline understanding of what we're really looking at when it comes to FEP. Starting with psychosis. Psychosis is a mental state characterized by loss of contact with reality, which may include hallucinations, delusions, disorganized thinking, or disorganized behavior. Hallucinations are a sensory experience that appear real, but are created by the mind that can affect any of the senses. Some hallucinations can include hearing voices, seeing things that aren't there or that other people are unable to see. We also have tactile hallucinations. Someone might feel an experience physically on their body, like maybe somebody putting a hand on their shoulder. And these can be a really scary symptom for someone to experience for the first time. Moving along to delusions. Delusions are a strongly held false belief that are not based in reality, often resistant to reasoning or contrary evidence. So an example of a delusion might be someone experiencing FEP thinking that the television is watching them. Despite what the people around them might say, that is their strongly held belief that often they're unable to reason with while experiencing psychosis. Paranoia is another key symptom we can see in FEP, which is an irrational or persistent feeling of being persecuted, harmed, or threatened by others. Paranoia can be very diverse in the sense that it can be targeted towards certain populations or certain situations. And we're going to be taking a look at the duration of untreated psychosis, also referred to as DUP. This is the time between the onset of psychotic symptoms and the initiation of appropriate treatment. Longer DUP is associated with worse outcomes. DUP is really a primary reason why early intervention for FEP is so important, because this period where the psychosis is not treatment can have long-term negative effects on an individual experiencing FEP. To really give some scope to FEP and the impact that it has, I wanted to share some key statistics related to FEP. First, approximately 100,000 people in the United States experience FEP yearly. So it's a big number that we're talking about there. So this is a large amount of folks who need targeted treatment interventions. FEP is considered the early period of symptom onset, generally categorized as the first 5 years of symptoms. As we get further into discussing CSC programs, we're going to take a look at the fact that that time frame will adjust depending on the program and the qualifications for each program. FEP-related healthcare costs are estimated at $155.7 billion annually, with the primary of these expenses coming from inpatient hospitalizations. Just to give some perspective to how big of a financial burden this is on our healthcare system, following Hurricane Katrina, which was one of the largest natural disasters that has occurred in the United States, the rebuilding costs were an estimated $120 to $150 billion. So we are essentially rebuilding our country from one of the largest natural disasters on an annual basis when it comes to treating FEP. One of the largest barriers to CSC programs is the cost. So the average cost per participant for targeted treatment is $17,810. So when you're thinking of a program even having 10 participants, this is a large financial burden on the organizations who are offering this treatment option. And to give a little context to FEP and when it's anticipated to start for someone, the average age of symptom onset is 15 to 25 years old. The onset tends to occur earlier in males, typically in late teens to early 20s, and tends to occur a little bit later in females. So we typically see early to mid 20s. The reason this time frame is even more significant is this is typically a very transitional period in folks' lives. People are moving away to attend college. People are starting to live independently for the first time. People might be further away from their support systems. This makes this a very vulnerable population with a symptom like psychosis that might go untreated for a longer duration because there isn't anyone who's going to see it or have that concern for those symptoms. The focus throughout my capstone project is on coordinated specialty care programs. So I want to give a good overview of what these programs are and how they offer support. So starting with what is it? Coordinated specialty care programs for FEP are comprehensive team-based treatment models, really focused on providing early and evidence-based interventions. These programs came to be following the RAISE initiative, which was launched by the National Institute of Mental Health in 2008. Starting to see the data on FEP continuing to grow nationwide, there really was a focus to identify what is the best treatment. Through thorough research, they found that having a comprehensive wraparound service is the best treatment modality for FEP. This initiative launched the first CSC program, which is now known as Navigate, which we will get into further in the presentation. So taking a look at these programs, what do they consist of? So these programs consist of medication management, group therapy, individual therapy, family education and support, case management, employment and vocational assistance, and peer support. The benefit of these programs is not only for the client experiencing FEP, but also for the families. When this is still something that's very new and unknown, it's scary and overwhelming, and this gives support for both the client and their loved ones to really get a sense of what the future looks like moving forward. What are those options? And a big component of these programs is having some accountability to ensure that folks are staying compliant with their medication, really with the goal that the psychosis stays treated and that we don't slip back to having that duration of untreated psychosis that has long-term negative outcomes. And who provides these services? CSC programs are, as I mentioned, a collaborative team. So we have psychiatrists, psychiatric nurse practitioners who are managing that medication piece. Therapists play a large role, both for group, individual, and family therapy. Social workers and case management play a large role in addressing social needs within these programs. And peer counselors have also been incorporated into a number of CSC programs, really to bring that connection of, you're not alone. I've gone through this. I know what it's like to come out on the other side where treatment is beneficial and symptoms are stabilized. So now that we have some baseline understanding of what CSC programs are, I wanted to share a couple of popular CSC models that we can see here in the United States. So I want to start with New Journeys. New Journeys is an exclusive program to my home state of Washington, where I currently practice. New Journeys was established in 2015. It, as I mentioned, is the exclusive model utilized within Washington state. And it's had state-funded expansion, which has included initiatives for certified peer specialists. New Journeys is facilitated through community mental health centers. One of the benefits of having an exclusive model to the state is all of the funding for FEP treatment goes into this program. So every county in Washington state has a designated community mental health center that offers a CSC program model. Participants must be between the ages of 15 to 40 to be eligible for these programs. Some qualifying diagnoses for New Journeys include schizophrenia, schizoaffective disorder, brief psychotic disorder, delusional disorder, and other specified psychotic disorder. Eligibility for this program requires symptom onset of more than 1 week, but less than 2 years. So that really hits home that need for these interventions in a timely manner, because once we're past that 2-year window, someone is unfortunately not eligible for this program. So those interventions really have to be targeted and getting folks into this care. In my current workplace outpatient setting, I'm able to refer directly to New Journeys by simply filling out a referral form online. And then that local community mental health center is able to connect with that patient and get them enrolled in services. If somebody is admitted inpatient in Washington state, there is a representative from that community mental health center who actually will come onto the inpatient unit, meet that prospective client, provide some education, and get them enrolled in this program. So it's a really great resource we have here in Washington state. Taking a look at the Navigate model, as I mentioned, this is the model that was developed by the National Institute of Mental Health through their RISE initiative. And this is utilized nationwide, and this program has been expanding internationally. So there's some further reach with this program model due to that research that happened through that initiative. So this is a strongly evidence-based model, and more states are adopting this particular model for that reason. Navigate targets clients between the ages of 15 to 35, and symptom onset must be less than 18 months for eligibility in this program. And then the third program that I wanted to share is a program called STEP. This is the Specialized Treatment Early in Psychosis. This model was developed by Yale University. It's embedded within community mental health, and it is exclusively located in the state of Connecticut. So this program really focuses on that academic piece. There's a lot of amazing researchers there at Yale who are continuing to test this model and how it can be expanded. And so this is a really unique CSC program model that is currently in effect. All right. So I wanted to share a case study to really connect the dots of everything that I've shared so far. So this case study shows a young individual named Aaron who is experiencing first episode psychosis for the first time. So we'll follow along through Aaron's journey, and then I'll spend a little time talking about that. All right. So that case study of Aaron really kind of shows that transition into FEP. Aaron started being more depressed and withdrawn, which had his family concerned. And then those symptoms of psychosis continued to expand from there. So really that highlighted that need for that early intervention through CSC programs and that ability to maintain some long-term outcomes. So now I'm going to be sharing an overview of my capstone project. So the capstone project at University of Kentucky really focuses on 3 products, starting with a systematic literature review, a conceptual framework, and a practice application. We'll be getting more in depth on these 3 products throughout the presentation, but to give a little bit of information, the systematic literature review, I focused on the research question, how can FEP programs be expanded throughout local communities? I utilized a screening tool to reduce the number of articles I included within my systematic literature review. Through my inclusion, I ended with 8 articles. I really wanted to focus on CSC programs within the United States. The reason for that being, we have a very broken healthcare system, as many of you know. And in other countries where there is access to health insurance through your local government, accessing care is going to look a little bit different than folks who are navigating the healthcare system here in the United States. So I really wanted to focus on programs like Navigate and New Journeys that are being utilized here in the US, and that's my focus throughout that systematic literature review. The second product of this capstone is a conceptual framework. So this was proposing a conceptual idea, which I focused on expanding access to CSC programs through a program development model. I really wanted to make a roadmap for organizations considering bringing a CSC program into their service line to really outline what would you need to do? What materials would you need to acquire? What staff would you need? How would you go about that? And so that's really the focus within my program development model. I utilize the theoretical frameworks of systems theory, strengths perspective, and intersectionality to really enhance that program development model. And the third and final product of the capstone is the practice application. I focused on workforce retention and expansion. So if we want to make more CSC programs, we need more clinicians who are trained in doing the work. I focused on a human resource management strategy, really focused on training and specialization opportunities to bring more folks into this workplace. Starting with taking a look at my systematic literature review, I really focused my research on finding out what are the barriers? Why are there not enough of these programs? What is standing in the way? In 2022, there were an estimated 381 coordinated specialty care programs for FEP in the United States. These programs did expand all 50 states and the District of Columbia, and the number of these programs has been steadily growing. As I mentioned, 100,000 people are experiencing FEP yearly. 381 programs is not enough. So what is standing in the way? Through my systematic literature review, I found three primary barriers. The first barrier being rural location. So folks who are living in rural locations have additional barriers than those living in large cities who have increased access. Some of the barriers related to rural location include transportation. If you live out in a rural community, you don't have access to public transportation in the same manner that you might in a large city where you have a bus or a train system to get where you need to go. There's also potential for limited or poor internet connection. If you have unreliable internet connection, you aren't able to navigate telehealth services in the same way that you would be in a large city. There's also reduced staffing options compared to large cities. CSC programs are a very targeted modality. To find clinicians who are trained in it is already challenging when you bring in a rural location that has less access and also potentially less compensation. That can be a challenge to have the staff to run these programs. And in rural locations, there's also reduced community support. There might not be as many social service agencies that can support with navigating folks to these CSC programs. We also take a look at funding. So any CSC program is going to have overhead. There's going to be program material expenses such as client workbooks and program advertisement flyers. Another large barrier that I found in my research is that a lot of the CSC program services are not eligible for insurance reimbursement. That's a huge financial barrier on organizations that are wanting to implement one of these programs into their service line. Through my research, I found that the average cost per participant is over $17,000. If you have a handful of folks in your program, you're looking at a big overhead expense, which if insurance isn't going to reimburse a lot of that, organizations have to find the funding to make that happen, whether that's through grants or private donors. There's also a significant cost of hiring and credentialing staff. If you are billing through insurance, you have to credential those employees with those insurance providers. That can be a big expense for an organization. There's also logistical barriers. So you have to have that collaboration with referral sources. If you're a community mental health center, you have to foster relationships with local hospitals and mental health providers to ensure that folks know about your program and they know how to get people connected. Program materials can also be a logistical barrier, as some program materials, like through the Navigate program, can be costly for an organization to purchase or challenging to acquire. And there's also the logistical barrier of physical space. A lot of community mental health centers are bursting at the seams. They don't have enough space. When you bring in such a comprehensive treatment model, you need physical space such as offices and group rooms. That can be an expense for organizations. And then we also take a look at staffing. CSC programs need numerous disciplines, such as psychiatrists, therapists, and case management. This is a very targeted client population. Not many clinicians have this experience, and that can make finding and keeping these providers challenging. There's also a need for clinical and leadership staff to provide the oversight in these programs. Through my systematic literature review, I really identified these barriers, which got me thinking, where do we go from here? How can we target these barriers directly to focus on expanding access within the community? After completing my systematic literature review, those barriers were clear to me. When I then looked at my conceptual framework, I really targeted this practice problem. Access is limited, and how can we go about expanding it? So with consideration for the barriers of rural location, the limited availability of trained staff, logistical barriers, limitations in funding, and the barrier from insurance, not reimbursing for a lot of the services that are offered, I wanted to take a look at a conceptual idea for how can we combat these barriers and how can we expand access, which led me to my program development model. I really wanted to highlight for organizations the steps that would be required to bring a CSC program into their service line. I wanted this to be a roadmap. I wanted it to say, these are the considerations that you would have to make if you wanted to bring one of these programs to life in your organization. I wanted to highlight the program structure, materials, leadership models, logistical considerations, and also start thinking about how are we obtaining and maintaining funding sources for these programs. When we're facing those barriers from insurance, we have to find ways to keep these programs running. And then there's also that staffing component. How are we hiring? How are we training? And how are we going to retain these employees? This led to my theoretical frameworks that support my conceptual idea. Taking a look at systems theory, I had to make considerations for these clients in CSC programs have large systems occurring within their lives. Their family, their friends, their community, religious organizations or affiliations. Development efforts for CSC programs has to address these complex systems, and also recognizing that when one system is impacted, there can be a trickle effect that occurs, impacting multiple systems within a client's life. This led to strengths perspective. So highlighting a client's individual strengths. If someone is engaging in a CSC program, they're motivated to be there. These are typically voluntary services, and a client had the strength to seek out and engage in that care. And I really wanted my program development model to highlight that. A large component of this is just acknowledging that client motivation. They're showing up, if they're engaging in treatment, that's a key part of CSC programs. And taking a look at intersectionality, CSC programs are going to serve clients from very diverse walks of life. And so we have to have consideration within these program models for race, gender, class, sexual orientation, and disability. These are also considerations not only for clients, but family and caregivers and the CSC program staff themselves. The third and final product that I created throughout this capstone was my practice application. So that systematic literature review that I mentioned really set the framework. I dove through research. I really took a look at what do we know about these programs? What is working? What is not? What are the barriers? What is preventing access for folks to get involved in CSC programs within the community? That conceptual idea really got me thinking, how am I targeting these barriers that I've identified through the SLR? And then the practice application continued to foster that growth and that movement towards expanding access. Through my practice application, I really took a look at what are the organizational challenges to staffing programs within the community. Starting with the workforce shortage in behavioral health. We don't have enough mental health professionals in general, let alone mental health professionals who are choosing to specialize in early psychosis intervention. In order to expand access, we have to look at how are we bringing more folks into this profession, and then how are we training and encouraging them to get involved in FEP treatment. This moves to the organizational challenge of specialized training requirements. CSE programs require a multidisciplinary team, and all members of that team must feel proficient in dealing with FEP and the treatment modalities that are offered within these amazing programs. This includes cognitive behavioral therapy for psychosis. Training opportunities are limited. A lot of clinicians are very well versed in cognitive behavioral therapy, but cognitive behavioral therapy for psychosis is its own specialty, and there aren't enough opportunities to get training and experience in that modality. This really leads to look at the limited educational pathways. So navigating through your master's degree program, folks aren't talking about FEP enough. There really isn't a lot of knowledge or training about CSC programs that are happening within these educational pathways. We have to take a look at how are we giving exposure to clinicians as they're progressing through their training to kind of encourage wanting to transition into one of these programs. Another large organizational challenge to staffing CSC programs is the low compensation. As I mentioned, these CSC programs are typically being facilitated through community mental health centers that have low operating budgets. They're spread thin, they're receiving grant funding, they're primarily receiving Medicaid reimbursement. And unfortunately, a lot of clinicians who work in this field are not compensated appropriately. So when clinicians have to make that decision of where they choose to work, often CSC programs might be overlooked for employment opportunities that offer higher compensation. And then we're taking a look at high burnout rates. Anyone who has worked with folks experiencing psychosis know that this is a challenging population. This can be emotionally demanding, and this has high turnover. When we're looking at the challenge of bringing people into this work and keeping them there, burnout's really something we have to give some consideration to. As I progressed through my practice application, I decided to focus on a human resource management strategy, really targeting expanding access through increasing staffing. If we're taking a look at workforce expansion and retention, we can really take a look at how we combat these organizational challenges to bring and keep amazing clinicians in this line of work. Some of the ideas that I explored in this human resource management strategy are implementing loan forgiveness or tuition reimbursement opportunities. This can be an incentive for clinicians who might feel torn on what path they want to take if there's that opportunity to have some loan forgiveness or tuition reimbursement. Organizations should focus on developing competitive compensation and benefit packages that can help retain skilled providers within these programs. Another focus within this workforce expansion is also looking at how do we bring in more diverse specialties into these CSC programs. So establishing career pathways for peer support specialists and case management. These are vital pieces in these CSC program models. And so creating opportunity for growth in these specialties. In the state of Washington with the New Journeys program, our peer support specialist is a certification that is relatively prompt to retain through a local community college. And so if somebody's working at a community mental health center in maybe a non-clinical role, giving some encouragement for someone to go back and obtain this certification can really help expand this workforce. And I also gave some focus to training and specialization. So this can be incentive for continuing education opportunities and providing funding for your clinicians to pursue some of these opportunities. Another incentive to encourage expanding education can be giving paid days off to attend CEU opportunities. This gives incentive for clinicians to continue to reshape and reharness their skill set. And providing professional development opportunities. So if a clinician is focusing on FEP, offering an opportunity for professional membership or subscriptions to academic journals that focus on FEP can be really vital in expanding that workforce. Through these 3 products of my capstone, I really came out with some key findings and implications for the field of social work. So starting with evidence-based treatment, the key findings of my SLR conceptual paper and practice application really support the efficacy of CSC programs for FEP. CSC programs result in improved long-term outcomes, reduced risk of hospitalization, reduced symptoms, improved social functioning, and increased involvement in employment and vocational opportunities. Another key finding that I took away is that access is limited. There are not enough CSC programs to ensure all individuals experiencing FEP have access. My hope would be that every individual experiencing FEP can access a CSC program in their local community. They shouldn't have to travel multiple counties away to access this care. It should be available where they live. And those 381 programs that I mentioned is purely not enough to meet this demand. And barriers. One of the key findings is there are barriers in place that are blocking access. And we need targeted efforts to combat these barriers to aid in expanding access. These key barriers including rural location, funding, logistical barriers, and staffing. And taking a look at what can social work leadership do? Social work leaders and administrators can take on active roles in the development of strategies to expand access. So that human resource management strategy that I explored in my practice application can be something that social work leaders can take to their board of directors or to their higher ups and say, hey, this is an amazing treatment modality, and this is how we can bring it to life here at our organization. And really that focus is on employee recruitment and intention. How do we bring people to this field, and how do we keep them there? How do we continue to provide this life-changing modality? And taking a look at the conclusion, what are the next steps? So now that we know that there are 100,000 folks yearly experiencing FEP, and having that knowledge that there are only 381 programs available nationwide, what are next steps? So my next steps for social work leaders, which I hope to be a part of this process, is implementing human resource management strategies, really focused on workforce expansion and retention in CSC programs. How can we develop more programs nationwide? How can we find the staffing that's required for these programs? And how can we continue to offer this treatment modality? Thinking back to that case study of Aaron, what would have happened if Aaron didn't get into Navigate? What would his life have looked like? During my time working inpatient, I saw what happened to folks who experienced FEP who didn't get plugged into the support that they needed. There's a vicious cycle of duration of untreated psychosis where folks end up back in the hospital and back in those high level of care. And these CSC programs really have that ability to step in and provide support and guidance, not only for individuals experiencing FEP, but also for their loved ones who need that support and navigation throughout this process. I also wanted to explore some secondary tactics. These are things that everyone can focus on. These are things anyone can do. A big part of this is going to be advocacy. This is going to be advocacy to increase reimbursement for CSC program services. This is a battle that is already being fought in a lot of states, really taking a look at Medicaid and Medicare and commercial insurance coverage, and really advocating for the fact that this is a life-saving treatment modality, and insurance reimbursement should not be a barrier in preventing access for folks experiencing FAP to get involved in these programs. This advocacy can include lobbying to your state, to your representatives, to Congress. There's that ability to speak up and say something, and that's a really key piece with advocating. There also can be advocacy efforts focused on increasing government and grant funding opportunities for agencies considering bringing a CSC program into their service line. So many organizations are able to keep the funding going to keep these programs, but what about that initial expense of starting a program? I think that's where a lot of this gap lies. And we really have to take a look at how can organizations get this support? I think that's a vital step that we're looking at. In addition to advocacy, there's really a need for clinicians to have more exposure to FEP and CSC programs. Thinking back to my undergraduate and master's education, both in social work, I feel like I didn't learn about either of those things. Certainly I learned about psychosis, but not the impact of early targeted treatment modalities for FEP. And if we're hoping to expand these programs, we have to also consider training and learning opportunities that come into play that are going to help foster that growth and opportunity within this field. I wanted to take a moment to just give some acknowledgments to some of the people who helped me through this journey. Starting with my husband, Kamal. Thank you for your unwavering love and support throughout this journey. It has been a long 3 years to get to this point, but I am grateful for your support. I also want to give a special thank you to my colleagues, my mentors, and all the educators I had throughout my educational journey for their guidance and inspiration. I can think back to my bachelor's program thinking, I'll never get a master's degree. And then I was motivated to pursue that. And in my master's program, I remember thinking, I'm done. I'll get my clinical license and be good. But here I am. And I also want to give a thank you to my coaches. I was a college athlete when I got my bachelor's, and I think I was more focused on the athlete piece. And I had some amazing people in my life who really motivated me to see beyond that and really to focus on furthering my education and seeking a sustainable career pathway. And I really feel that I've had the opportunity to do that. I wanted to give a special thank you to everyone who was able to join today. I know I have some family, some loved ones on this call, but also some colleagues in the DSW program who are navigating this journey themselves. I have included my email address on here. It's just my first and last name @gmail.com. It's a great way to reach out to me with any questions, or if you want to keep this conversation going about this topic. This is something I feel really passionate about, and I'm always willing to pick up a conversation about. And then I'm going to be facilitating some time here for questions and answers. But I wanted to, before we get into that, just see, does anyone have any kind of clarifying questions or anything that really stood out in this presentation that you want to highlight? I know I shared some big statistics throughout this, and this was a lot of information coming your way. So I wanted to see if anyone just has any general comments before we get into the Q&A portion. And feel free to raise a hand, to type in the chat, whatever feels most comfortable.
Sarah, I just want to highlight some of the initial statistics that you shared that really, I mean, they're very impactful and just draw a picture of why it is so important that we're even talking about this today.
Yeah. Thank you, Victoria. I know that's a really key thing with this topic. When I saw that initial statistic about the financial burden on our healthcare system that occurs because of FEP, I really struggled to even find something to compare it to. When we're talking about $155.7 billion, that's a number that I can't even wrap my mind around. And to think that that comes through so many facets, that's looking at emergency room visits, inpatient hospitalizations, that's looking at inpatient and outpatient settings. That cost is such an exorbitant number. And when I found that comparison to Hurricane Katrina, I think that really hits home, right? You know, think of the devastation of Katrina. Think about all the rebuilding that came after that. And to think that FEP is causing us to navigate that on a yearly basis is really just astounding. Also, that statistic about just the cost for one participant to be in a CSC program is over $17,000. To think of an organization having maybe say 10 people in one of those programs, you're looking at a huge overhead expense. And I think if we really want to look at how we expand access to CSC programs, we really have to take a look at the financial piece. How can we get insurance to be reimbursing for these services? How can we find ways to make some of that cost more manageable? Especially when we're taking a look at community mental health. I'm not sure if anyone on this call today works in community mental health, but I think we know that financial struggle community mental health is going through, especially kind of in current times where some things are looking a little rocky with some of the Medicaid and Medicare support that's available. It's really a daunting task for community mental health to think of bringing one of these programs into their service line. And I think when we also look at the amount of staff that's required for this interdisciplinary model, right? That's a key piece here. If you're needing medication providers, therapists, case managers, the hiring and salaries for those employees alone is a huge expense. And so I think, you know, a key piece with this process as well is also looking at how do we obtain and how can we continue to have the appropriate funding for these programs? And so that's going to be a large component of further research, I'm sure, as we take a look at the goal of expanding access to these programs. All right. So it looks like we got a couple things popping in the chat there. I'm not sure, Victoria, if those are new or old.
Just a couple comments. The audio was initially low, so a couple of us had commented on that, but and then Kamal says, "Great job."
Thank you. Just to open it up again, I'm not sure if anyone had any questions or general feedback or comments that they wanted to give about this topic. Again, I want to thank everyone who was able to attend today and be a part of this process for me.
Well, if there are no questions, I do just want to thank everyone for joining us today. And please join me in congratulating Dr. Whybark on a job well done.
Thank you. Thank you again, everyone, for being here today. Feel free to reach out to me by email if anyone has any questions. I also recorded today's presentation if anyone would like to have any access to that. I do also on this presentation have my references listed if anyone wants to dig a little deeper into this topic. There's a lot of great things that can be learned about FEP, CSC programs, and really that initiative to expand access.
Great job. Thank you.
Nice work.
Awesome. Thank you so much for being a part of it and helping through that.
You are so welcome. It's such an interesting topic. I live up in Connecticut, so I'm in Yale country. I worked for them and access their services all the time for our folks. And there's a real need, and I'm glad that you're looking at it. So,
Awesome. Thank you so much.
all right, take good care. Have a great rest of the day.
Thank you. You too. Bye.
Bye.